I think we are waiting for John to reconnect, Daniel.
Yes, yes. Sorry, John, it has happened again.
Yep. I guess I'm just too talkative, you guys. I'm pushing the envelope of your seminar session there, Daniel. My apologies, but I'm nearly finished.
Sorry, I knew this could go up to 7 p.m. Kenyan time. So, yeah.
Okay, so I'm going to share my screen again.
Yes, you can share the screen.
You got it?
Yes.
Oh, okay. So again, this is another system that has to be commissioned by the physics team. So when I was talking about commissioning being the testing of to make sure that the tools we use are appropriate, that's not just testing of radiation units. It's also testing of any of the imaging systems that we use, the CT scanners that we use to do this patient target delineation. And it's also a commissioning of the treatment planning system. So we don't just buy the equipment from the manufacturer and assume it works the way it should. We actually buy the equipment, we thank the manufacturer for delivering it, and then we test it to make sure that it works the way it should. And that's the job of the physicist. So let's look at how the delivery goes. And I've shown you a little bit about this, but I'm using some slides from a colleague who's the head of physics at another center in the province, just to give you an idea of how radiation delivery has changed over time. So I've already said, we try not to treat with just one beam, because if we treated with one beam, the dose would be given at the surface. So what we actually do is we bring in multiple beams so that the dose is greatest here and less there. It's not quite as clear on this grayscale as it was before. And this can lead to 3D conformal therapy. So if I did this just with beams that were delineated with a port at the end of the machine, so if I had some kind of shielding that would come in and make a square or a rectangle, what I would be treating if I put these four beams together would be I'd be treating some kind of cubic area to a uniform dose. That's what this kind of treatment would give. Yet the target might be very complicated. My tumor might have some complicated shape. Here I'd be treating the tumor, but I'd also be treating normal tissue on the outside. So again, I have this process that enables me to identify how I should better shape those radiation beams. And in the head of this machine, I actually have a device that's called a multi-leaf collimator that on many modern devices that enable us to shape this beam. In some centers and maybe many centers in Africa, they would not shape it this way. They might make some kind of blocks out of a dense material that could shape the beam. And so I can shape the beam from each direction. And by shaping the beam from each direction, I can better isolate the radiation around this target. So by shaping this beam, I can better shape the radiation that I'm going to deliver. And that's, in this case, I'm still looking at a uniform intensity of the radiation throughout this beam. And that would give me this kind of treatment. And we would call this three-dimensional conformal therapy because we're conforming the dose that we're delivering better to the target that we're trying to treat. And that's, again, because each of these beams would be uniform. But there's nothing that says I have to keep this shape in this configuration while the radiation beam is on. Perhaps I can actually move these little leaves of they're tungsten leaves that are individually controlled. So it's like little motors that can shift where the shielding is. So I could potentially move these so that I now have the intensity changing across this radiation port that I'm treating with. And that enables me to better, oh, where's my mouse? To better carve the radiation so that it even better shapes the target that we're trying to treat. And this approach is called intensity modulated radiation therapy. And in many centers in the world, this is what we are trying to achieve. In fact, this is already a huge advance. And I think we've forgotten when we talk to various groups how to deliver radiation, we've forgotten that this was already a huge advance. And this requires a lot of technology, sometimes technology that might not be appropriate for a certain setting. Anyway, that's another talk completely for Yakov and I in the future. And how is this shaping done? It's essentially by adjusting those leaves in the multi-leaf collimator so that I get an intensity modulation of the delivery. And just to show you some other advances that have been happening, early on we would treat with a limited number of beams. As we progressed, we started treating with more and more beams. And many of the modern linear accelerators today, they don't even treat with individual beams. Stationary, the machine is rotating around the patient continuously while those leaves are moving. And there's all kinds of dynamic control that's going on. So in modern external beam radiation therapy, there's a lot of control of this linear accelerator as it's rotating around the patient. All kinds of things are happening in the head of the machine to make sure that we are giving this dose delivery that we want. And so there's a lot of quality assurance that needs to be done to ensure that these deliveries are correct. And physicists are involved all along. So if I look at how modern radiation therapy plan is generated, as I said, we do some imaging, often with the patient in special immobilization devices so that they're always maintained in the same position throughout their treatment. A physician will contour the target volumes that they're trying to treat and the organs at risk that they're trying to miss. And they will give this to the planning staff, who will now generate some other structures perhaps, and will generate the treatment plan that's appropriate for this patient. Often this involves an interaction between the oncologist, the doctor, the planning people, and the physicist to say, what is the best approach for Mr. Smith or Mrs. Jones? Many treatments, they're all very similar, and so some standard approaches can be used. But very often one gets a patient with some complications in how their anatomy goes. The organs at risk are really close to the target. So how do we weigh, what do we try to hit and what do we try to miss? And so there's an interaction between the physicians, the physicists, and the planning staff to make sure that this is done appropriately. So that then the plan is generated, and the radiation oncologist will review the plan and just make sure that the doses that he wanted to give or she wanted to give are given to the patient. But then there is a lot of quality assurance done by the physics team. Was this plan appropriate? Is it the way we usually do things? Is it according to the protocols we've set for this treatment? So there's a huge physics component to make sure that this plan that was generated for the patient is appropriate and done correctly. And in our center, physicists check about 75% of the plans that go through completely, and the other plans are checked at a random process because there's some standard treatments. So there's, again, physics involvement in the generation of that plan. And then the final thing, some of the other things we check is we actually make sure that the dosimetry is correct and that the machine is operating appropriately. One can imagine when we were using these larger fields, these square fields and rectangular fields to treat, if the patient moved or the target moved or something happened, we were still treating the disease. We might have been, depending on how we were doing things, we might have been overdosing some of the normal tissue, but during the course of movement of treatment, this might have moved back and forth, so the normal tissue kind of got averaged out, but I was always treating the disease. I could do radiation dosimetry by just checking with a point detector, maybe an ion chamber, that the dose in this field was correct, and everything would be fine. But if we start to shape the beams more sophisticated, then the same shifts that were okay here all of a sudden become problematic because I start to miss the target. And if I'm giving higher doses because I'm getting conformal, I might be causing a little more damage. So this becomes much more critical that we actually make sure that the patient is in the correct position, the targets are all there. And the dosimetry in this situation, when I'm shaping the beams, is a lot more complicated. So the physics quality assurance that is required as we move from here to here is considerably more. And much of the physics time these days on quality assurance has increased considerably in many centers. And essentially what it is we want to make sure we're treating this, and we want to make sure we're not doing this. So there's physics is very involved in all of that checking. And one of the things that's very, very important is to make sure that all of these control parameters that were set in the treatment plan have gone over to the machine correctly. And in our center, what we would do is we would actually look at what is the expected intensity modulation from any beam coming in. So, you know, on a very sophisticated treatment, I might have a lot of modulation coming from a particular direction, and how could I verify that that's happening? And in Kingston, what they will do is they will actually use part of the linear accelerator design is it has a portal imaging device. So it has an imaging panel that is at the exterior of the patient on the other side of where the radiation beam is coming from. So I have the radiation beam coming, the patient is here, and I have this imaging device that I can look at to see that the intensity modulation that was planned by the treatment planning system has actually been delivered to the unit. And we do this before the patient goes on. So one of the steps in our clinic is to validate that the control parameters have gone to the machine appropriately by looking at the fluence patterns. And there's all kinds of metrics that one can use to make sure that that's acceptable. So we actually deliver the actual patient plan at all of the various angles that are going to be delivered, and we make sure that the expected fluences are what they are before the patient gets their first treatment in Kingston. Different centers do that slightly differently. So again, one of the other things that the physicist is involved with. And just to give a few more examples of what physicists would do, if we have a new technique that we want to use, the physicists will usually do a lot of testing before that technique is delivered on a patient to ensure that the technique can be delivered. So here's an example of some measurements we did with a particular type of dosimeter that could measure dose in 3 dimensions. And we actually looked at, before we did our very first intensity modulated treatment in our clinic, we actually simulated that treatment on a test phantom. So a thing that simulated a head and neck. And we put in this detector and we assured ourselves that the doses we were delivering were the doses that the treatment planning system and our process was predicting. So one of the big things that the physics team also does is, before a specific treatment technique is used, the physicists guarantee that that technique is going to be appropriate. And essentially what we do is we use the phantoms and go through the treatment process with this phantom and with dosimeters to ensure ourselves that the process was correct. Another approach that we used, a similar kind of thing, for many years, if there were metastases in the brain, the treatment modality was to treat the whole brain with a uniform radiation. This is very complicated because it's treating a lot of the brain that does not have disease to hit small targets that might have disease. And there was only so much of this you could do before the brain was getting the effects of the radiation, and one would have to stop this treatment. What we've moved to is a more sophisticated treatment where we actually look at where these metastases are and treat with very, very small beams. And that enables us to really confine the radiation again to where the disease is. And that enables us to retreat these patients if this disease comes back. But if you're targeting that radiation so specifically, you want to make sure that you're doing this delivery correctly. And again, the physics team, before our very first stereotactic brain treatment was done in Kingston, the physicists spent quite a few months making sure that the machine was delivering the doses as we want, building particular phantoms that we could put various detectors in, and confirming that the radiation delivery was as we were hoping to do when patients started in this treatment. And I'm going to end with just another example of where physics comes in. So I have this radiation clinic. I have a number of bunkers that have treatment machines in them. These are giving high doses of radiation, but I have people who are working here. I have the staff that are running these machines that have to be safe with all this radiation. I have the general public that might be walking around the hospital. And so there's a lot of radiation safety concerns in the construction and in the design of a radiotherapy department. And again, it's the purview of the physicist to make sure that rooms are made with appropriate shielding and designed in an appropriate way that, again, people who might be in other parts of the building that the radiation beam could be pointing to are all safe. So another, just an aside of another task that the medical physicist has. Again, all of this work is collaboration and working with various people. And in many centers, a lot of our work is also training young medical physicists. So these are characters, various people that are being trained, that were trained in the last decade in my center. these are all senior physicists now at their particular centers. Actually, this young man went to the dark side. He's no longer a physicist. He became a radiation oncologist. We were very sad about that, but that's what happens. Anyway, just to say that the other thing about being a medical physicist is you are working with a lot of people. You're working with physicians, you're working with the staff who actually do the treatment deliveries, and you're also working with people from industry who are trying to supply you with equipment. So it's one of the exciting parts of being a medical physicist is you're not just stuck in a room doing calculations. You are actually working with colleagues and in a very interactive environment. And with that, I thank you for your attention. I know this has gone on long. I tried to tell a story, and I hope you found this story interesting. And if you have some questions, I'm sure we can have a bit of a discussion now. So I'll stop the share. And believe it or not, my talk is over.
Oh, thank you very much, John, for the interesting talk. For me, it was very exciting. Even if I had a cup of coffee, I think I could have forgotten to sip it. My question, I have maybe a few questions before I give my colleagues and students a chance to ask their questions.
Okay.
For me, I'm thinking about the Meru Cancer Center that is coming up. And I'm just wondering, between the two techniques you told us that we have teletherapy and brachytherapy, which would be an easier one to implement in terms of cost? And how much would it cost?
Well, brachytherapy is a little bit less expensive on the capital side. To buy the equipment is a little bit cheaper, but it is not. It's not applicable to all cancer sites. Now, I was just talking to a fellow yesterday who is in Africa and in a center that has both brachytherapy and external beam. They have a very active program, but still most of their patients are treated by external beam because you just have more cancers that you can treat. Although, again, in centers where there's a lot of cervix cancer and such, brachytherapy is a very effective treatment. So the quick answer is brachytherapy is cheaper, but it doesn't do everything. So you know, to just limit yourself to brachytherapy maybe would bring the team on, and you could start with that because it would be easier to do the implementation. But you wouldn't want to stop there. You need to expand a little farther. And I don't know, Yakov, if you have anything to add to that.
Yeah, well, basically this is correct. I mean, you know, in brachytherapy are mostly limited to either areas where you can insert a source in the patient, either through a catheter that goes inserted surgically, or intracavitarily through a cavity on the patient, but it's limited in the applications. And brachytherapy also requires, I would say, if you are doing modern brachytherapy, you still require all the ancillary imaging equipment that you need to do proper brachytherapy treatments. So it's not just the device to deliver the radiation. So the differential is significant in just basically the delivery machine, because most of the rest, I mean, it's still about the same, perhaps a little bit less shielding, also, because the shielding for linear accelerators requires more, heavier walls and so on. Doing brachytherapy alone, I don't know there are many centers in the world that do just brachytherapy. So, in a sense, I mean, although brachytherapy started very early in the, after the discovery of radioactive materials, nowadays some brachytherapy is done with electronic devices that do not have a radiation source, but the technology is it's a little more complex, and it has to be, it's more critical to understand very, very well the dosimetry at very short distances. So there is no simple answer, I would say.
Yeah, and the other point I'd make, Daniel, is people often think that the critical cost is the capital equipment. In fact, that's very important, and that's often a barrier for centers being developed. But the other cost really is the people, and you're going to have the same kind of team. You're going to still need physicists. In fact, you need more physics input in brachytherapy because the physicist needs to be involved in every aspect of, including the treatment. You need the therapist to deliver. You need the oncologist to do. So you need to build that structure, and it's not just the device itself that's determining the cost of the cancer center.
Thank you. Another thing that I also think found very exciting is that before you now administer the actual radiotherapy, the physicist would kind of play with radiation dose that is probably use a phantom to simulate the amount of radiation and whether it's the correct dose and the at intended levels and the location. And can software play a role in kind of simulating the intended dose distribution?
Yeah, I mean, again, so the treatment planning system has a lot of software that is doing that already. In many centers, they will have a separate, maybe not a full treatment planning system, but they'll have a separate software system to also do the dose calculations and then compare the two and use that as a validation. So there are quite a few centers that will just use independent calculations to do the verification that everything looks correct and that a particular plan looks correct. The philosophical debate then is, well, how do you know that that information went to the machine correctly? So it's a good step to make sure that the calculations themselves have been validated by some separate approach. But there is a debate in the community whether that's good enough or if more needs to be done. And again, I think some people would say that the new machines are so sophisticated that they don't often make mistakes. So we don't have to check everything. But I personally, I'm an old-fashioned man. I don't always find that very reassuring. I would prefer that we do more complete measurement-based validation, which might be just based on fluence patterns on an imaging device. Again, I'll let Yakov.
Yeah, I mean, of course, that is a concern, but two things to keep in mind. One of them is phantoms. They are different. We call them phantoms in general because they are not human, but they are many times designed to do different things. Sometimes they are just basically a simple block of or container with water where you can move a dosimeter across and measure those distributions. In many other cases are what's called anatomical or semi-anatomical phantoms, which are dedicated to test different things. Like, for instance, there are semi-anatomical phantoms to test the quality of beams for reconstruction or obtaining the data from the CT scanner. So you have objects in that phantom of different densities to confirm that, I mean, what you get, the electron densities that are sent to the treatment planning system will be accurate. That's one type. And the other phantoms that are many times done are semi-anatomical. They kind of mimic different organs in the patient, you know, with in the vicinity of different density materials and so on. And those are very important in commissioning. You don't need to do every plan on them, but when you commission and you test a new implementation of a system, that's very important to do what's called the end-to-end test, where you basically simulate on a patient that it's plastic, and you go through all the steps of the process. Now, we have to also remember that many of the accidents that were reported in radiation therapy were not just because the machine, we didn't measure so accurately the dose of the delivered by the machine and so on, but process controls, that the process itself was not strict enough, and you had places where people deviated from the correct process, and that's what caused an accident. And usually those are, it's a totally different topic, I mean, than dosimetry. And there has been a lot of documentation and methods to try to avoid those what's called mistakes, which are not mistakes, they are mistakes and accidents and errors and so on, and uncertainty. So there is a all different topic that perhaps at some point we should have a presentation about that, but that's more, you know, would be worthwhile on a clinical training program.
I'm just looking at the clock and we're getting a warning that we have about 8 minutes left again. So I'm willing to come in again, but just a warning.
Okay. Murwa, do you have a question?
Thank you so much. It's an interesting talk and presentation. Maybe I would say this is the first time I'm interacting with such a group, and it's the first time being a radiation physicist. I'm seeing very important applications of what I learned, and therefore I'm growing a lot of interest on that.
We didn't hear what you said, Murwa.
I'm saying that this is the first time I am now getting the practical application of what I learned in radiation physics in my master's. And therefore it's very motivating for me. It's a good talk that has really highlighted quite a number of issues in medical physics. And what I would do is simply to appreciate and say, we need more and more from you as our senior partner. Thank you so much.
Oh, again, it's a pleasure. And you know what you said is actually quite important. So we do a lot of book learning. We do a lot of preparation. But at the end of the day, it's a very motivating field. You know, I don't think there's a better job that a physicist can have than a medical physicist, because I mean, all of physics is important. We get to understand more about nature and about how the world is. But in medical physics, every day you are impacting somebody's life, and that's very exciting. And working with others, which is very exciting.
Sure.
So
sure.
I'm glad that even a senior fellow like you can find some excitement in a new talk. That's good.
Thank you so much.
I want to bring a few students to ask some questions if they do have some questions or some comments. So I'll start with, let me have Samuel. Samuel.
Me, please, not me.
Okay, good evening.
Good evening.
I'm very excited with the presentation that you guys have done.
Oh, thank you.
We've really learned a lot, and we are waiting for more. Like, being that the first time we are interacting with the ideas to do with the medical physics, for the topic of today of radiotherapy is very interesting, and we are very much interested. Thank you and have a good evening.
Okay, thank you very much.
Thank you. Thank you for the feedback.
Now, Alex is not with us, but he has a colleague who is in theoretical physics. But I am hoping that I can snatch him from theoretical physics to medical physics. Is Kennedy. So Kennedy is doing masters in physics, but in astrophysics.
Oh, okay.
Yeah, maybe Kennedy, you can come and.
Okay, hello, bro.
Hi,
Hi, good evening.
good to meet you.
Good to meet you too. I see I'm very excited listening as an astrophysicist. I feel so nice. Maybe I was like to jump ship to medical physics as Daktari my baby have said. But also we can we learn more on it.
Yeah. I know two colleagues who were in computational astrophysics and in their past, and they eventually became medical physicists because they actually could appreciate that some of the computational stuff is very, very similar. Again, we deal with interactions with pretty dense material. There, water and people. You guys do with interactions that are very diffuse as photons are traveling through the universe. But some of the physics is very, very similar. And so I know two colleagues who actually moved from astronomy and high energy astrophysics to radiotherapy. So there is hope.
It's true.
One of the things that it's important, and I think that's why physics or a background in physics, in general physics, is so important, that medical physicists can bring a variety of skills into the medical field, things that other people in the medical field are not familiar with. Physicians don't have that deep understanding about interactions and so on. It's not that they don't know, they are very valuable and they are very important in treating patients. We wouldn't be able to do any of that ourselves, but bringing the other areas of physics, thermodynamics and nuclear physics, and a lot of things in computational physics, as John mentioned before, some of these algorithms are based on interaction computations, some of them on the Carlo computations and so on. And a lot of the progress that has been done in the clinic is based on those, advances. So everything is very valuable, and people being able to shift from one application of physics principles to another area, it's extremely valuable.
That's for sure.
Yep.
Okay.
And the thing I should point out is we are physicists first, right? You need to have a strong physics background. The science is not difficult. The science is not, I cannot solve many of the types of equations that you guys are solving. So it's not that skill set. but you need to have a good fundamental physics understanding so that you know when the things that you're calculating are correct or not. You have to have that understanding of when there is a problem or not. And it's a physicist that has that, right?
That's for sure. Otherwise,